It is such a privilege to introduce our speaker for tonight. Nancy Hart, MD, is a professor emeriti of pathology and obstetrics and gynecology at the University of Florida College of Medicine. She spent years as a high-risk obstetrician learning medical means to reduce prematurity, which were in large part expensive and ineffective. She learned about social determinants of health and population health while spending time in U.S. Congress as a Robert Wood Johnson Health Policy Fellow. Upon returning home to Gainesville from her time in D.C., she became a public health activist and advocate and was tapped to serve on Pregnancy-Associated Mortality Review, Domestic Violence Death Review, Child Death Review, and Fetal Infant Mortality Review. Research focused her research on mapping of health and social outcomes to identify neighborhoods experiencing mother and baby health inequalities. And that resulted in some major community action. By participating in and starting interprofessional working groups, many changes were implemented to address identified inequalities. And many of you who have been in Gainesville for a while know of some of those things that were identified. The most successful and lasting changes were systems and policy changes which benefited women and their children. And it is with great pleasure that I introduce Dr. Nancy Hart.
Thank you. Thank you. Can everybody hear me okay? Sound check. Woohoo. Okay, what I did today, because I haven't reviewed this topic for a while, I wanted to make sure I brought you the most up-to-the-minute data. So I started with the OECD website. And if you have this piece of paper I handed out, does anyone need one? Because I have more. You need one? The OECD is the Organization for Economic Cooperation and Development. Have you ever heard of that? You need one? So the OECD started after World War II when people who never had a constitution before decided to have a constitution. And because we had a constitution that was ancient, we were considered to be experts in constitutional law. And now that we look back on our Constitution, you know, I see you laughing, you know, we kind of wonder, but anyway, these people aspired to democracy, if not as good as what we have, better than what we have. And they decided to band together in order to share policies that made their citizens live better lives. So the OECD has always been available to us because it's like a meta-analysis of health outcomes. And I must tell you, from my days in US Congress, nobody cared at all what was going on in other nations in the world. The hegemony, the amount of hubris and ridiculous attitude that no one could tell us anything about how to run a country made us fall behind. We have fallen behind. And that's what question number one is to illustrate. The OECD, in other words, for all of these 38 countries, average life expectancy is 80.3 years. You might ask, who has the best life expectancy? Do you think it's the United States? No. Ours, in fact, is the worst of all of the OECD nations. And when I learned that, I was shocked. I couldn't believe it was true. And I had to dig around to figure out how that could be, why that could be. So our life expectancy is now 76.4 years. And among the countries that are down there at the bottom with us, Colombia, Hungary, Latvia, Mexico, and Poland. Now, the ones who are doing well, Australia, 83.3 And in the world of life expectancy, a few months is a big deal. So we're 76.4, Australia 83.3, Korea, and I'm sure this is South Korea because North Korea doesn't tell us anything about what's going on there, 83.6 years. Japan, get this, 84.5 years. And Spain, 83.3 years. So we are down in the doldrums in terms of what life expectancy is. And I want you to think for a minute about why that might be, and I'm going to come back to it. So interestingly, if you ask people in these OECD nations how they rate their health, do they think their health is good? Which countries have very small percentages of people saying that we have poor health? Korea, Japan, Germany, or the United States? The United States. We think our health is great, and we are deluded. We're wrong, okay? So 3.1% of people in the United States think our health is poor, but Japan, which has a life expectancy of 84.5 compared to our 76.4, 13% of people think their health care is poor. Really? Really? So Korea, Japan, and Germany all are in double digits in the number of people who rate their health as poor. And we are at 3.1%, and we are wrong. So let's go to number 3. Compared to OECD nations, what are we doing well in the United States? I'm not here to hang a lot of crepe, okay? We've had some major policy changes that have been good for us. And one is smoking. So the OECD average of people who smoke is 16%. Only 8.8% of Americans smoke. And you and I have all witnessed this happen, because remember, you used to be able to smoke in a room like this. Not no more. You know, you cannot smoke indoors. There are a lot of taxes that have been placed on purchasing of cigarettes. These were good policies, okay? Our policymakers helped our health when it comes to smoking-related illness. Air pollution's another one. We have 14.5 deaths per 100,000 due to air pollution, but the OECD average is twice that, 28.9 per 100,000, which means that the Clean Air Act worked. Are you with me? You know, there are people who think the Clean Air Act is of the devil and we should undo it, but actually it's very good for our lungs and the lungs of children, especially those who live in urban areas. Alcohol. We've done fairly good with alcohol, but we could do better. 9.5 liters per capita are consumed in the United States. 9.5 liters. I'm sure I do that. I am sure I consume 9.5 liters. But the OECD average is 8.6. So the United States is a teensy-weensy bit above the average, but we're way far from the countries who are on the alcoholism spectrum, okay? And obesity. How are we doing with obesity? Pretty bad. Yeah. 33.5% of Americans have a BMI greater than 30. Is that shocking to you? I find that shocking, but if you've been to Disney World recently, yeah, you go, wow, I'm skinny compared to these people. This is great. Yeah, so OECD BMI greater than 30 is only 19.5%. That's the average of these 38 countries, and we're at 33.5, and we're way off the scale. Okay. Most OECD, here's the crux of the matter. Most OECD nations have more than 95% of the population with healthcare coverage. Think about that for a minute. Most nations who did not have a constitution at the time of World War II, who were run by imperialist leaders, you know, kings and emperors and etc., dictators of all kinds, they all adopted constitutions after World War II that made healthcare a right. Did you know that in the United States, healthcare is not a right? Did you know that? In fact, one of my favorite things to do was to have the med students count off 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. All the ones, you are going to debate that healthcare is a right. And all the twos, you are going to debate that healthcare is a privilege. And I remember being in the back of the room just to watch the debate. I wanted to see what they came up with because I helped them find the arguments for both sides. And students would come up to me and say, Dr. Hart, I got a 2. I don't want you to think I believe this, but I have to argue that healthcare is a privilege. But I don't believe it, okay? Okay, honey, good, good. So, healthcare is a privilege, not a right in the United States. But which nations in the world of this 38 nations do not achieve 95% coverage? Well, we know the United States is one, right? Because welcome to Florida. Poland, Chile, and Mexico all do not have 95% healthcare coverage. And in Mexico, it's only 72%. We're doing a lot better than Mexico since what? The Affordable Care Act. Yeah, since the Affordable Care Act. So in the OECD report, it lists which countries have made the greatest improvements. We are one. Which country has the highest per capita healthcare spending and the highest percent GPD spent on health? You know this one, right? We do. We do. And it's not by a little bit. I'm going to show you a bar graph, and you'll have to squint your eyes to see, are you kidding me? Our bar is that tall? It is really tall. So we spend $12,000 plus per person on healthcare in the United States and 16.6% of our GDP. But the OECD average is $4,900, like less than half of what we spend in this country, and 9% of the GDP. So we're like complete outliers with these other countries. So let's talk about other countries that have really good outcomes. Austria spends $7,000 per person and 11% of their GDP. Switzerland spends $8,000 per person. It's 11% of their GDP. Germany spends $8,000 and it's 12% of their GDP. These are countries with very much better outcomes that we have that spend much less money than we do. So we have to ponder, what are we doing wrong policy-wise to make this expenditure so high and our outcomes so bad? So here's a shocking fact. Which country has the smallest number of doctors and smallest number of hospital beds? And you better believe that these are policy decisions that our government and our country has made. United States has the smallest number of doctors, 2.7 per thousand. Of course, Gainesville is the huge exception to that. That's why you all live here, right? Yeah, because Gainesville is in the 99th percentile for number of doctors per capita. So this is where you want to live if you need doctors. But the fact of the matter is that our policies have allowed hospital conglomerates to close rural hospitals. And because hospital conglomerates work on a profit model, those not so profitable rural hospitals have been allowed to close, depriving rural residents of access to hospital beds. So the United States has 2.8 beds per 1,000 people. And Korea has 12.8 beds per 1,000 people. Again, this is South Korea. I don't think we know what's happening in North Korea. And we have 2.7 doctors per 1,000 people, not in Gainesville. But Italy has 4.1 per 1,000. And remember all that consternation during COVID about what was happening in Italy? They have way more beds and way more doctors than we have. So these are policy issues to make that funnel so tight that we all know young, beautiful people who wanted to become physicians that couldn't get into medical school, don't we? I know lots of them. And I've had to help them circumvent the obstacles or maybe become a PA or a nurse or some other health professional because we want them as health professionals, but they cannot get into medical school. We have that funnel too tight. And the hospital bed issue, that's all because we allow hospital system to be for profit. Okay, so this is just to preface what I really want to talk about, which is mothers and babies. And I'm telling you why we need to care deeply about mothers and babies. Probably not too many of us are having babies anymore, right? Are you not having babies anymore? Yeah, yeah. Well, mothers and babies are the canary in the coal mine. If we don't care about what happens to the most vulnerable among us, I think Jesus said something about that, right? If we don't care about the most vulnerable among us, we are making a big mistake in terms of the fact that we're all taxpayers and it matters how people get a start in life because they'll be more expensive later on if they don't get a good start in life. And that's why Alachua County, you should be very proud, has a children's trust. And this was a policy that was allowed in previous administrations, not the current administration, that allows us as local taxpayers to tax ourselves just a little bit more and keep that money locally with no control from the state government. And we decide locally how to spend that money on behalf of children. Did you know that? It's super cool. It's super cool. Yeah, and it's not a lot of money because Gainesville's a small town, but it's better than nothing. Okay, so now I think I told you a lot about the OECD, and am I going to be able to advance? Okay, and who do I point to? You? Okay, so here's what I want you to look at. Here's the United States expenditures per capita. See how tall that column is? Going all the way down to India, expenditures per capita in terms of healthcare. And you would think with all that money we spend that we're doing good things. But, oh yeah, as a share of GDP, which is just a different way to express it. And what do we spend our GDP on besides healthcare? Defense. And have you ever noticed that Canada has a dinky defense budget? Would we ever let anything happen to Canada or Mexico? They don't need to spend money on defense. We do for them and for whoever else happens to be our ally, but they're on our continent, so we care a lot about them. Okay, so anyway, 16% of our GDP, and these are the most recent data I could find. Life expectancy, what does OECD have? 80.3. Japan is way up at 84. And here we are down here at 76.4, right there with Argentina and Croatia. So do you guys know why our life expectancy has fallen rather precipitously? Probably that's some of it, but I think there's a bigger one. COVID, actually? Yeah, no. What do you think it is? Drugs. Oxycodone has not done to other countries what it has done to our country. And does everyone in this room know someone who died of a drug overdose because they started with oxycodone because they had an orthopedic injury and it just led into a death spiral? I do. I know multiple people. And I got to say, Janet, you probably don't remember this because you didn't get visited by these people. But as an obstetrician, I was still practicing obstetrics when the drug company reps came around and said, we have this really good drug. It's oral. It's a great pain reliever, and you can't get addicted to it. Well, when they figured out that that was wrong, do you think they ever came back and told us that was a mistake? No. No, they kept marketing it, even though they knew that was no longer true. And that has cost us a lot of people. And that's why I think that's the main reason our life expectancy has gone precipitously down over the past, maybe since 2005 or maybe 2000. Yeah. And here's a really interesting graph where the red bar going down shows you how much ground was lost by that country. And here's what's really tragic. Look how low we were to begin with. And then look how far down the bar went. So we were already in the dregs, and now we're double dregs. Yeah. And we think our healthcare is so good. That's what's so preposterous to me. Okay, so let's get back to mothers and babies. Ooh, do you think we're having a thunderstorm? I wanted to talk about mothers and babies because that's what I'm interested in. I started out as an obstetrician. I wound up as a pathologist. Birth and death were my areas of expertise. I'm a nothing now. I'm just a citizen just like you guys. But Alachua County is no bed of roses. For a place with so many hospital beds and so many doctors, you would think the people who live in the shadows of these buildings would have great access and great outcomes. And here's what's really shocking. And then in order to scrape the scab off your wound, I'm not going to leave you bleeding. The Band-Aid will be applied because there are things that we can do, believe it or not. So let's talk about maternal mortality first, because I think because maternal mortality is so rare, we don't talk about it as much as we could. Alachua County only has like 290,000 people in it. So when you measure maternal mortality, it's got such a high denominator that we don't have very many. So even if 2 mothers die, it jerks our statistics around. So we have to look at 3-year rolling averages, we have to look at the whole state, and we have to look at the whole nation, and we have to look at all other nations too. So what do we mean by maternal mortality? Somebody who had a pregnancy, which may or may not have come to term, doesn't matter if it did or didn't, and she died within a year of that. Now, when I was on maternal death review in the state of Florida, the purpose of that committee was to talk about pregnancy-related deaths. In other words, we were trying to improve obstetric practice and hospital practice so that women who had a complication of pregnancy would not die of it, okay? And that's what the committee was for. But somebody there at the state health department had the brilliant idea to write down all of the women who died during that year, but didn't die of an obstetric complication. For example, what if they died of domestic violence, homicide? What if they died of suicide? What if they died of a drug overdose? What if they died of a car wreck? Well, to me, Nancy, little miss, I never follow any rules. I'm like, I'm kind of interested in those high-risk OB problems, but I think we're really reaching the law of diminishing returns there. People have good blood banks. People know to transfer moms when this or that happens. People are being delivered at centers that can transfuse them if needed or do elegant surgery if needed. But wait a minute, we aren't even thinking about all these women who are dying in car wrecks or of drug overdoses, and their babies are left without a mother, just like these OB complications. We should care about those families. So I had this brilliant idea. It was really a cuckoo idea. And luckily, my son was an MPH student at the time, and I got him involved. And my boss in the autopsy service, I got her involved. And we pulled autopsy reports of all the women that died of these non-obstetrical causes for a number of years and reviewed all of those autopsies because they become public record. We could get them. And not only could we get them, we could get their toxicology reports. And I couldn't make heads or tail of these toxicology reports, but there was a really good toxicologist at UF at the time. And my boss in the autopsy suite was very familiar with tox. So I learned a lot about tox. I had no idea how many of these young women were dying of drug complications. So what happened was, and this is Nancy just being a dumb genius in a way, like I was an irritant for that committee, and they decided forevermore that that committee would review those non-obstetrical deaths as well. And it's part of what they do. And they even changed the name of the committee. And they never gave me any credit. I don't really care. But the fact that they do it, to me, is really important. But you must know that one of the things that's been happening in recent years is that the public health department in the state of Florida has been trimmed down to bare bones. You know, there are huge buildings up there that are empty now. So when I tried to update some of the reports that I was used to always getting when I gave these talks, they don't exist anymore because those employees do not look at data anymore. Yeah, sad to know. But here's why I got so interested in the moms that did not die of obstetrical causes. We got to this law of diminishing returns because we got pretty good at managing platelet abnormalities, bleeding abnormalities. We had better anesthesia. We had better ICUs. We had good pulmonologists. I got to tell you, in high-risk OB, if I got in a panic over one of my patients, I had the best ancillary doctors in anesthesia, intensive care medicine, hematology that would save them. All I had to do was say, I'm out of my league. Save this person, and they did. So it really wasn't, I really don't see that we can do that much better with obstetrical complications, except for one thing that's really interesting. Remember I told you about the Children's Trust? Well, we decided that one of the very first things we were going to offer was a nurse home visit to everybody that had a baby in Alachua County. And those nurses who go into those homes have found a few women who would have died if they hadn't measured their blood pressure, for goodness sake. Because once they go home from the hospital, which is in like 24 hours, nobody sees them again. Do you know why nobody sees them again? Because Medicaid will not pay enough for a postpartum visit that any OBGYN has time or inclination to do it. And even if they do, even if it's UF where you're training residents to do postpartum visits or the public health department that'll take care of everybody, the Medicaid transportation will not take the baby to the mother's appointment. So when your baby's 4 weeks old or 5 weeks old or 6 weeks old, who are you going to leave it with while you go to have your postpartum checkup? You're not leaving it. You're not leaving it. So if you can't get a ride, that Medicaid transportation won't take you. Is that the dumbest thing you ever heard? So wait, I was thinking about this, Janet, you'll appreciate this. They all go to the pediatric visit because the Medicaid transportation takes the mom to the pediatric visit. You're not going to put a baby in a van and send it without a ma, right? That'd be stupid. So I said, why don't we have the nurse practitioner for the OBGYN department go over to the peds clinic and see the mom while she's there? Because then you don't have to worry about this stupid Medicaid transportation. This is a policy matter that if we wrote enough opinion editorials, I don't know where, because we don't have a paper that takes them anymore, but you know what I'm saying? We could do something about that. Yeah. Okay, so these are Alachua County maternal deaths in a 3-year rolling average, because it doesn't make any sense to look at 1 year at a time. It just jumps up and down. It still jumps all up and down, the 3-year rolling average. But look how much worse we are than that orange line, which is the state of Florida. I don't understand this. Why are we so much worse than the state of Florida in maternal deaths? Except here at the end, it's looking a little bit better, starting about 2015. And that could be about the time we started the nurse home visits. But I think it would be rash of me to say that those nurse home visits have saved enough women from dying that now we're starting to go below the state maternal mortality rate. But let's just hold in check our curiosity about that and see where this goes. And this is maternal mortality in the United States. It's climbing up year after year. Look at the total, goes up every year. Non-Hispanic blacks goes way up. Non-Hispanic whites goes up. Hispanics goes up. What are we doing wrong in this country that our moms are dying? So I have a hypothesis or two, but I wonder if you have one because we reviewed some of the risk factors. Obesity. It's a big one. And with obesity comes what? People don't die of obesity. What do they die of? High blood pressure, congestive heart failure, diabetes complications, right? Obesity is really a bad complication in the United States. And if you ever wondered why we're fat and Europeans aren't fat, have you been to Europe and said, wow, everybody's normal weight here? Have you ever wondered that? Do you know the answer to that? High fructose corn syrup. They don't have it there because they don't grow corn. In this country, it's a commodity. It's in so much food. Have you ever read the labels on your favorite crackers? Did you have a better idea? Okay. That is a really good question because it's quite high. It's quite high, but it's gone down a bit. His question was, does the C-section rate have anything to do with mortality? So I guess you need to know which came first, the chicken or the egg. The fact that she needed a C-section, was she at risk, or was the C-section placing her at risk? Because I can tell you, obstetricians basically do 2 operations. They're really good at it. You know, like there is no orthopedic, well, there are a few orthopedic surgeons that only do hips, but you know, most surgeons do all kinds of different procedures, but obstetricians really do C-sections and tubals. Well, no, they don't. Obstetricians don't. So they're pretty good at getting those bleeders stopped. They're pretty good at that anatomy. And if you have a good anesthesiologist, and a lot of people always ask me, oh gosh, I probably shouldn't even say this, where should I have my baby? I said, it doesn't matter about the obstetrician. Go to the best anesthesiologist you can find, and they're at UF. Just saying. Because you can die if the anesthesia screws up. Yeah, anyway, that's just me being me. Okay, so like I said, we decided to expand our definition of pregnancy-associated death. And turns out pregnancy-related death has to do with a complication of the pregnancy, like hypertension or congestive heart failure or bleeding. But the natural causes, that would be someone who had, let's say, lupus or a cancer of some kind that happened to die during that period of time. That would be a quote-unquote natural cause, not caused by the obstetrical issue. But the traumatic deaths were what really fascinated me. The accidents, homicide, suicide, and overdoses. And what we found out was that in the state of Florida, transportation accidents or car wrecks are the #1 cause of death in women in the first year after they have a baby. Homicides are #2. Accidental poisoning, which is drug overdoses, #3. And suicides are #4. And then we get to the OB things like cardiomyopathy, hypertension. So, you know, I rationalized maybe we should train obstetricians to find out who's in a domestic violence relationship, find out if there are guns in the home, find out if they feel safe. Well, it turns out we have a thing called a Healthy Start screen that does all of that. But if you are our daughters, their obstetricians don't think they need that screening and they don't get it. Well, I'm here to tell you everybody needs that screening. Because you can't tell by looking at a woman whether she's at risk of being murdered by her domestic partner. Anyway, so dumb junk continues to happen in the training of OBGYN people. And this is from a paper that I wrote with my son. And you can just see how many more transportation accidents there were compared to the things down at the bottom, like cardiomyopathy, amniotic fluid embolism, infection, etc. the OB complications that we are trying so hard to reduce. So here's a way to think about a policy change that could be helpful. Have you ever thought about how many times a provider sees a pregnant woman? By the end of the pregnancy, if she sees the same provider all the way through and not a different one each time, which can be a problem, they are BFFs. She will tell her provider anything, everything, stuff the provider doesn't even want to know. But this is where you can make a difference in these social determinants of health. You can protect someone who's in a domestic violence relationship or help someone with unstable housing or hunger at home. And I can't think of any other place in medicine, except maybe your oncologist, where you see the same person over and over and over for a long time. But people going to oncologists are not vulnerable in the same way as pregnant women and their children. So again, this is where I think we should retrain obstetricians on these social determinants of health and make it part of their job. And you know why they don't want to do it? It's so logical. They don't want to be sued because they didn't ascertain that somebody was a victim of domestic violence. Obstetricians get sued for hangnails. You know, they get sued for everything. They don't even want to be OBGYNs anymore because they get sued so frivolously. And then to add on all these things, we went down to the Florida OBGYN Society and said, no, really, you should ask them about seatbelts. You should ask them about drug use. You should ask them about domestic violence. And the obstetricians were like, I'm not asking them any of that because then I'm responsible. So it's complicated, isn't it? Yeah. Okay, infant mortality, a baby born alive that dies within the first year. It's kind of the same as for the mom. And guess what? The United States does stinky bad when it comes to infant mortality. And this makes no sense to me because we probably have the best neonatal units in the world. People come here from all over the world to learn how it is we save a 24-weeker, how we ventilate a 24-weeker, how we figure out how much blood or antibiotics to give them. We're really, really good at neonatal intensive care, but we still stink at keeping babies alive for the first year of life. So you got to ask yourself, what are they dying of? Well, first of all, prematurity is a major cause of infant mortality, and we have way more prematurity. Why do we have more prematurity? This is why I left OBGYN and went into pathology, because I thought if I understood the placenta better, I could unlock this prematurity question. And actually, maybe that's true, but we had not devised the tests yet. And brilliant Ed Wilkinson taught me a lot about placentas, and Bill Donnelly too. And they never taught me how to figure out how to prevent prematurity. I didn't get it. No. So we have higher death rates for full-term infants as well, which would be things like SIDS or abuse or neglect, social determinants that are not so much an issue in other OECD nations. And why is that? Well, because all of those women and their children have so much more social work involved and doctors and nurses involved in their lives. Whereas we just kind of say, boop, you had the baby, there's nothing more to charge. The hospital can't charge, the doctor can't charge, so boop, you're on your own. Good luck, honey. Very, very, very screwed up the way we take care of young women. And so the different causes of infant mortality, the preterm birth complications, as we just alluded to, birth defects are still really common. And that is not going to change. If anything, that number is going to go a little higher if people can't terminate their pregnancies when a birth defect is identified, which we didn't call it doing an abortion when I was in high-risk OB. You know, we might have called it induction. You know, we'd induce her labor, and we wouldn't induce a baby that was likely to make it to the nursery and be resuscitated. She would just hold it until it died, but she didn't have a baby with brains that were sticking out the back of the skull. You know what I mean? Like we never made those decisions for women. And this is what Amelia Cruz taught me. I don't know if any of you knew Dr. Cruz. She was really a great mentor and teacher. And she said, your patient is in a boat. Your job is not to steer the boat. She's steering the boat. Your job is to get in the boat with her and make sure the boat gets where she wants it to go safely. So if the patient wanted to terminate their pregnancy, we helped them. If the patient didn't want to terminate their pregnancy, we helped them. And we were very careful in discussing the birth defects that we ascertained they had with them so that they made that decision. It's a very personal decision. And there were people that I took care of who continued their pregnancies that I just thought, oh, I would never continue this pregnancy, but they wanted to, and we helped them. And there were people who terminated their pregnancies. I remember one lady, I tried to convince her, yes, your baby has no arms, but we have really good prosthetics now. And she's like, no, no, my baby has no arms. I'm terminating the pregnancy. And so we did. So anyway, injury, sudden death, SIDS. And when I was in Memphis, we had a lot of SIDS because people who lived in the projects put their babies in bed with them all the time. And if they were overweight or under the influence of alcohol or drugs, they would roll over on the babies. And even the weight of an arm of an adult could suffocate a baby. We had lots of SIDS in Memphis. So we decided, this is another Nancy Hart, you got to be crazy. Okay, we'll do this. Every baby that was born got a little onesie that said this side up on the front of it. And you know how baby t-shirts kind of cut a little lower in the front than in the back, so they would get it. So that was because their moms and their grandmoms were telling them, no, 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 the baby goes belly down. And we were like, no, 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 belly up. So anyway, we did that, and they are still doing it. And I was there in the early 2000s, and they're still doing it more than 20 years later. Oh, let's see. Problem births at the United States. I don't know why. We just are so much worse than all of these European countries in preterm births. But like I said, Wilkinson and Donnelly couldn't show me in the placenta why we were having all these preterm births. It was social. Social. And if you invited me here to talk about what happened in SWAG, it's the exact same thing. Yes, birth control can help women space out their pregnancies, but once those babies are born, if you don't attend to their housing vulnerability, their domestic violence problems, their food insecurity, the outcomes won't be good. It's very complicated, very complicated. And actually, in my foggy little mind, the easiest thing we can do is give people contraception who don't want to be pregnant. And why it isn't free and readily available everywhere, even in high school. You can't even talk about it in high school. Can you believe that? Anyway, I'm obviously not the queen of this country. So these are old data. I couldn't find the new data, but when I last researched this, we ranked 3rd internationally in survival at all low birth weight groups. In other words, we have really good NICUs. We can keep those babies alive. But we ranked 9th in survival at normal birth weight. That's social. That's social. And I've also done an autopsy on a baby who was a preemie that survived, went home with a mother who could not manage the gastric tube, the gastric feedings every 2 hours, the apnea monitor. This young woman, she was 18 and not, I wouldn't say she was brilliant, okay? She was not, I wouldn't call her mentally retarded, but she was challenged. And she had a very complicated baby to take care of. And do you think anyone helped her take care of that baby? No. And that baby died. And then they tried to get me to say at the time of autopsy that she should be put in jail for neglecting it. And I said, oh no, you got that backwards. We neglected her. We neglected that baby. That is our fault. It's not her fault. It was a terrible tragedy. And then the last thing you want to do is put that mom in jail. It would have been wrong. Wrong. Okay, so anyway, we talked about these causes of infant mortality. And here we are in Alachua County. We are the blue line at the top. Why can't we do as well as the state of Florida? And let me just say this, these are not college students' babies. This has nothing to do with UF. These are the people who were born and raised here and are having their babies here. Compared to the state of Florida, we have a lot more preemies, and therefore we have a little bit more infant mortality. Our nurseries are good, but even when those babies survive, they are complicated to take care of for the rest of their lives. They may have respiratory issues. They may have neurological issues. They may have a seizure disorder. They may have cerebral palsy. So it isn't easy. Just because we can keep those babies alive, we can't necessarily make them perfect. So it would be good if we could figure out how not to have so many preemies. And here we are again. Alachua County has a lot more infant mortality than the state of Florida. I don't know why, except that we do not take care of young women having babies in this community as we could. Do I know what all the answers are? Well, no. The Children's Trust is trying, and if you have any brilliant ideas, I'll take them. So let's talk a little bit about the way forward, because I promised I'd rip the scab off your wound and I would put the Band-Aid on. What did we do wrong with health reform? We never expanded Medicaid. That was probably not very smart. So people at 138% of poverty and below, they only have Medicaid when they're pregnant and for a few weeks after. Now, the babies stay on Medicaid, but the moms don't. And I'm here to emphasize, we have to take care of those mothers, their seizure disorders, their drug addictions, their depression, their domestic violence, their chronic conditions, and the family planning they need should be so accessible, which is why I think it should happen in Pete's clinic. Because they will take their baby to the pediatrician. They will neglect themselves, always. And what would interconception care look like? If these women were on Medicaid, if we had Medicaid expansion and they stayed under healthcare all that time, we could take care of their diabetes, their asthma, their seizure disorder, their high blood pressure. We could talk to them about things like use seatbelts. So here are the policy opportunities. Expand Medicaid. It's a non-starter in our state government. Even the Medicaid expansion advocates aren't even going to try to do it this session. I find that pitiable. Now, the way other states have dealt with a very gerrymandered state government is they put it on as a constitutional amendment. We're having trouble getting it on as a constitutional amendment. It was tried a couple years ago and not been tried since. I have no idea what happened, but not happening. We could make the Medicaid that we have more attentive to the needs of young women. For example, the fact that transportation won't take a mother to her postpartum visit, that is a policy question that we could solve locally in our state. We don't need the federal government to approve that. And this is what the map looks like. The orange states are the states that did not expand Medicaid in the Affordable Care Act. There aren't many left. There are only 10 left. And I researched today what all those other 9 states are doing. They're all doing something except for Florida. Florida's just dwelling with it and somehow finding it acceptable. So why would we want to expand Medicaid? If anybody asked you, what might you say? You might say, well, we can reduce mortality. And we know our mortality is pretty bad based on OECD comparisons. People would get their chronic diseases cared for and their disabilities cared for. Just think of the reproductive health advantages. If we don't like abortion, I'm not a huge fan. Why don't we give people contraception? Hello, it's available. And the behavioral health, the substance use disorder, the depression. We have many people with depression, anxiety that needs to be addressed. The economic impacts on the providers. It would have been a boon for providers to have Medicaid expanded. And hospitals. We probably wouldn't have closed so many rural hospitals if we'd had that payer source for those people. And if you care about health disparities, I happen to, although we're not supposed to talk about it so much anymore, we could address those. And the social determinants of health. I think housing is huge in Gainesville. For example, if you look at a living wage and how much money of a living wage is supposed to go for housing, there is no rental available in Gainesville for that amount of money. And it's because, you drive down the street, you see all those fancy schmancy student apartments going up. Even the more humble apartments have been turned into fancy schmancy so they can charge $1,400 a month. There's nobody in poverty that can afford more than about $500 or $600 a month for a rent. So what's happening? We have lots of homeless families. And mothers and children should not be homeless. And there are countries in the OECD bloc of 38 nations that will never allow that. Unfortunately. Okay, so that is the Band-Aid I have to put on. There are things we could do. We could expand Medicaid, and we could even improve without expanding Medicaid. There are things we could do. And I would like to be quiet for a couple minutes and see if anybody has a comment or question. I think we'll do question.
I was a pediatrician in Chicago and in Indiana for 40 years. And most of our patients were Medicaid, pediatrician. Luckily, I had other patients that paid the bills. Most pediatricians could not have more than 50% of their practice being Medicaid because they were only paying maybe 33 to 40% of what we normally would charge. And after, you still have the office people to pay for, you have the rent to pay for. That doesn't go down to 30% or 40%. It goes up every year. And Medicaid in Indiana and Chicago did not keep up with that. So even though these poor families had Medicaid for their children, they couldn't find people that would see the kids.
So gratefully, thankfully, in Gainesville, people will see pediatric patients with Medicaid. You may have to wait a little longer for your appointment, but guess what? You cannot get dental care because they don't even get enough money for a dentist to buy the stuff to fill the cavities with. Even if the dentist wanted to just give away the care, and some of them do, you still have to pay for the stuff. And also, a dentist is like a surgeon. They never operate alone. They must have an assistant who needs to be paid. Yes, ma'am.
Thank you. I'm just thinking with the current climate in Florida, it seems to me that everything you've talked about is going to get worse. And one of the things that I keep hearing is that a lot of doctors are leaving the state. Is that correct?
Asking my OBGYN friends what's happening, because the American Association of Medical Colleges put out this bulletin and they were afeared that people who are applying for OBGYN residencies would not apply in a state like this. But that has not been observed yet. Now, it could be that there's going to be a little bit of a lag. And as time goes on, the number of applicants for our residency positions will go down. So, yeah, I think there's a fear of that. And really, we all want to learn how to do all the procedures, even if you never really plan to use them, because after all, you do a DNC all the time for people having miscarriages. And if you have to dither at the bedside and watch somebody bleed and say, well, I got to make sure there's no heartbeat before I do this DNC. Well, yeah, it's really hard. I don't know how the high-risk obstetricians are doing it, because our stock in trade was to diagnose the congenital anomalies and then give the family the options. but now there aren't options.
I used to volunteer with the March of Dimes. And just as I sort of ended my tenure with them, they were coming up with some real interesting suggestions about infant mortality and why premature births were occurring. Have you come across any of that literature? Have they gone anywhere with it that you know of?
I know very little about what March of Dimes is up to, but it's such a good organization. They hired away my map guy. So I made all these maps that identified the neighborhoods with the health disparities here in Gainesville. He went to National March of Dimes in Washington, D.C. to do mapping on a national level, and he had already done state of Florida level maps. So I know that they're really interested in focused delivery of supports in neighborhoods where people really need it. And how interesting that, did you know that if people are Spanish speaking and they come to this country and they do not speak English yet, they do not have elevated infant mortality rates or prematurity rates. As soon as they become bilingual or their children grow up bilingual or English speaking, the poverty kicks in and gives them all the decrements of poverty. So there's something about the way Hispanic culture takes care of pregnant women, regardless of poverty, that they didn't have the stress of wondering out where their next meal was coming from, whether they'd have a safe place to sleep, whether they'd have something warm to put the baby in. It's amazing. And we should pay attention to that when newcomers to this country have better outcomes than natives. Tells us something really scary.
Shall we end on that cheery note?
Well, it's good to know, isn't it? Somebody's doing well.
Okay, all right.
Thank you,
Boy,
Dr. Logan.
thank you, Nancy. Okay, well, I hope we'll see you all and even more people next month to talk about another cheerful topic, immigration. Thank you all for coming.